Hi everyone, this is Hossein Heshmat, interventional cardiologist, and in this video we'll be discussing contrast in PCI, how to reduce the dose of contrast to avoid contrast-induced nephropathy, and we'll go through a quick case vignette. Acute kidney injury after PCI is defined as a 25% or more increase in the serum creatinine relative to the baseline. The incidence varies in low-risk populations to 5% up to 50% in high-risk populations. The hazards associated with contrast-induced nephropathy may include long-term dialysis, and even if the serum creatinine returns to the baseline, observational studies suggested an increase in the short-term and the long-term risk of cardiovascular events. And of course, there is a handy tool which is available on most mobile devices that can be used to predict the risk of contrast-induced nephropathy. The Mehran score, it takes into account hypotension, the use of intra-aortic balloon, congestive heart failure, diabetes, baseline creatinine, the volume of contrast that has been injected. And the higher the score, the higher the risk of contrast nephropathy, and also the higher the one-year mortality. And as you have seen in the previous slide, most of the factors associated with contrast-induced nephropathy are not modifiable, like heart failure, hypotension, baseline serum creatinine, etc. So what's left to the interventionist is manipulating the contrast, either the type or the dose. 1 decade ago, we thought that specific types of contrast are associated with lower risk of contrast-induced nephropathy, but the recent meta-analysis suggests that there is no significant difference between low-osmolar contrast media and iso-osmolar contrast media regarding the risk of contrast-induced nephropathy. So what's the lowest volume of contrast that we can do a PCI with? Surprisingly, the answer could be zero contrast. You can do PCI without contrast at all. This was first suggested by Ziad Ali in 2016, and through the rest of the presentation we'll be discussing the strategies that you can adopt to reduce the contrast dose to the minimum, even up to zero. So what strategies do we have? First, we have to separate the diagnostic from the PCI so that the volume of contrast we give during the diagnostic doesn't count in the PCI volume of contrast. Number two, this strategy applies mostly to stable coronary disease patients, not for patients with complex coronary artery disease. The use of IVUS is essential, as well as the use of fractional flow reserve measurement. Separating the diagnostic study from the PCI gives a chance for the kidneys to recover after the volume of contrast, gives you a chance to study the anatomy properly and have a mental mind map of the vessels so that you don't need to give puffs of test contrast while you're navigating through the coronaries. And of course, it gives you a chance to hydrate the patient before PCI. Hydration seems to be one of the most effective tools that we have in our hands to minimize the nephrotoxic effects of contrast. During PCI, don't keep contrast in the room and use it only as a bailout procedure in case of life-threatening situations. Try to go for the radial approach if you're familiar with coronary cannulation, the radial approach. Keep the echo in the room, do a quick study before the procedure, and compare it with the study that you do after the procedure to make sure there's no pericardial effusion and there's no perforation. When you're cannulating the coronary, you have to do that without test of contrast. And you know you're inside the coronary when the PCI wire goes inside the coronary. Try to put as many wires in the side branches as you can, because they will allow you to mark the lesion and position your stent properly. Use of IVUS for assessment of the vessel diameter, of the lesion length, of the plaque characteristics, and the success of PCI is essential. Use of pressure wires to judge the severity of the lesion and to judge the hemodynamic impact of PCI is also very helpful. And I would strongly recommend going through this nice review article recently published in JACC that details different strategies, device-based and imaging-based, to reduce the risk of contrast-induced nephropathy before and during PCI. They discuss more complex strategies such as the use of impella, renal guard, aspiration of contrast from the coronary sinus, dextran-based OCT, and other tools. And we'll go now through a quick case vignette that I like to call walking on the edge. Because in patients with mild chronic kidney disease, the risk of contrast-induced nephropathy is low, whereas in patients with severe chronic kidney disease who are already on dialysis, there's nothing to lose. Whereas the highest risk patients are those with severe chronic kidney disease who never did dialysis before, and you know that in their natural history that they will be needing dialysis anyway, even if they are not giving contrast. But when they have an acute coronary syndrome and they need contrast, the risk of contrast-induced nephropathy and dialysis is so high. So you're pushing their dialysis early, which no one likes, neither you nor the patient. Our patient here is a 63-year-old female with long-standing diabetes, hypertension, chronic kidney disease stage 4, with an eGFR of 20 mL per minute. She had a long history of coronary disease with multivessel PCI in 2009, PCI in 2007 that was complicated by acute renal failure and hemodialysis, which marked a tragic event for the patient that she was not willing to go through again. When she had acute coronary syndrome again, she preferred to go for CABG rather than PCI, which she did 1 year earlier. However, she had recurrent admissions with non-ST ACS and acute pulmonary edema over the last few months. And with every admission with non-ST ACS, she refused angiography because of the risk of dialysis. She finally accepted after being rejected from other hospitals, and after she presented with life-threatening acute pulmonary edema, where was she about to be intubated and mechanically ventilated. And here's her Mehran score. She gets 5 points for heart failure, 3 points for low hematocrit, 3 points for diabetes, 6 points because of her very low eGFR. The total score is 18, which makes the risk of CIN 57%, need for dialysis 13%, and 1 year mortality 33%. And in this patient, we didn't have the luxury of separating the diagnostic from the PCI. We had to do them all in one session. She had a Lima graft to the LAD, so we couldn't go from the right radial, and her left radial artery was occluded from previous catheterizations, so we had to go through the femoral. And as you can see, the left coronary arteriogram, it shows an occluded stent in the LAD, patent stents in the circumflex with some diffuse disease. Her right coronary arteriogram had a significant stenosis in the proximal mid-segment, which was the probable culprit. And as you can see, the use of biplane angiography definitely reduces the volume of contrast. Her Lima was working fine with a clear body and anastomosis, with the flow of the Lima filling the distal mid-LAD and spilling to the proximal LAD. So now 3 injections, 2 for the native vessels, 1 for the Lima graft, with a total volume of contrast of 21 mL. So we went and we cannulated the right coronary with a JR guide catheter, and we used the Verata wire, the pressure wire, as our workhorse wire. We crossed the lesion, and this is the IFR value, 0.82, meaning definitely significant stenosis. Having the pressure wire inside, we pre-dilated the lesion with a 2mm balloon, and then we went with an IVUS, a volcano IVUS, to assess the severity of the lesion after ballooning, the vessel size, the plaque composition, and to understand which size of the stent are we going to use. As you can see, these steps didn't involve any contrast, and the total volume of contrast that we use up till now is 21 mL. And here you can see the IVUS images. The right coronary seemed to be a big vessel. If we take the measurement from media to media, the vessel will be probably a 4mm vessel. And the minimal lumen after balloon dilatation is 3.6mm squared. And you can understand that this plaque is a mixed heterogeneous plaque with no significant calcification. So we went ahead with an everolimus eluting stent, 3/34. We deployed the stent. We post-dilated with an NC balloon 3.5. We took a look again by IVUS. We had to upgrade the NC balloon to 3.75 to achieve proper stent apposition and stent expansion. And all these steps were without contrast, so the total volume of contrast now is still 21 mLs. And here's the final physiologic assessment. The IFR, which was 0.82, now normalized to 0.98. So we know there's no significant residual stenosis. There's probably no hemodynamic edge dissections. We confirmed that by IVUS. And as you can see, the minimum lumen area of the stent, which was before 3.6, now it's more than 8 millimeters square, signifying a successful procedure. And there's proper stent expansion and proper stent apposition. And here's the final control angiogram that shows a very nice result in the RCA. We had to waste extra 6 mLs of contrast just to give the patient and her referring physician a visual proof of success of PCI. As you know, not everyone is familiar with the IVUS minimal lumen area and the physiology cutoffs, so we had to do this final angiogram to confirm our success. And here's how her serum creatinine behaved throughout the whole hospitalization. We started with very high values, coinciding with her admission with a life-threatening acute pulmonary edema that declined after some medical treatment and improvement in the hemodynamic status. As we did the angiogram and we did the PCI, there was some rise in the serum creatinine that plateaued after 3 days and then returned to the baseline in almost 2 weeks, and then went even better than the initial baseline value after almost a month. We were so glad that the patient pulmonary edema resolved, her angina disappeared completely, and there were no recurrence of her non-ST acute coronary syndromes over the following few months, and she never required dialysis. So to conclude, contrast nephropathy is one of the most notorious conditions for patients and for interventionists. We should do all what we can to prevent it, although it sometimes would be very difficult because of the patient comorbidities. Trying to achieve zero contrast PCI is feasible only in some selected conditions, but in most cases, minimizing the contrast dose to the minimum is possible through using the tools that we described. Thank you, everyone.